all over, and now I'm here, and yeah, we work at Temp Regional and American Work Retail Valley. I know that you recently had a talk from my partner, Dr. Ogle, about the different levels of trauma and trauma centers, and know about the plan for this hospital trying to obtain level 3 center status. So I want to have a talk, basically just some slides about the pre-hospital evaluation of the trauma patient and some ATLS basics, and then there's a case that we can go through. I welcome your interjections and questions and input. Let me know if you want to say something. So you are all in Draper. So, okay. And what medical certifications training is it? BLS, ACLS? What is your
ALS ground transport?
Okay. So I have a study that is very pertinent. So basic evaluation, which you're all very familiar with, but same thing that we do. We receive patients starting with ABCs, airway being our most important doing this primary survey. Is this kind of similar to your assessment? How you see patients? Okay. And basically just stabilizing and transport, those are your main goals. For airway specifically, these are some principles that we use in the hospital. I'm curious to see if you've ever heard of this lemon sort of acronym before. It's interesting. Anesthesiologists teach us in medical school about how to evaluate for a difficult airway. You probably just do these instinctively, where you're looking for any signs of a difficult airway. So facial trauma, if the patient has a bunch of saliva or soot or anything, maybe some broken teeth if they have an obstruction or even a large beard, and then measuring, this is more for planned intubation, but looking at how narrow their vocal cords pharynx are going to be and anticipating some adjuncts. Mallampati is not as applicable to you. You're not going to be sitting there measuring their tonsils and their palate, but it's good to think about these things, right? So when you have a patient with a really short neck and really fat, maybe they do have some stuff in their mouth that's difficult airway. What I have read, I did some research about pre-hospital evaluation of patients, in particular in traumatic brain injury patients, but it's very obvious that you don't have a lot of time. The time is of the essence, so getting patients to a trauma center is very important. So it's actually faster for you to do this kind of scoop and run idea, concept, where especially if you're close by to trauma center or hospital like Lone Peak, not wasting the time to intubate, but just trying to ventilate them like a bag of alcohol, right? Maybe getting out whatever is obstructing them, suctioning, as you all have suction capabilities, yeah. But when you're actually on the ground before you have the patient in your ambulance, it's you don't necessarily have all that available. So, do you ever use like an oral airway or a nasopharyngeal airway right there? You like have it in your pocket or in your bag. I haven't done many ride-alongs, so it's interesting for me to talk to you because obviously we have everything available and it's very limited what you have. So what I found very interesting is I gave a talk to I think Eagle Mountain or Saratoga Springs, and they told me that they don't do entitled CO2. Okay. Okay. They were about 50-50. They said that some units don't. We're trying to implement it into all stations, but across the country. Okay. Do you have a continuous reader or just great? So, do you put that on patients that you're worried about a difficult airway, or only patients that are intubated?
We have certain protocols that we follow. So, for example, there are patients that have CO2. Use LNAs will still enter end-tidal.
Great.
ET tubes end-tidal.
Okay.
End-tidal is a cannulus that we use.
That's awesome. Okay. Wow. And so does that show up on your same monitor? That's the same for us. I know that not all units have that, but that's very, very good to hear. I don't know if you know about this study, this EPIC study, and the Brain Trauma Foundation just released these new guidelines that outlines basically what should be done in the pre-hospital setting. It decreases mortality in TBI patients by 30%. Yeah, 30% is what they found. And all across the country, several centers, it was a systematic review, and then they came out with these guidelines. So it sounds like this is what you're following. Assessing to see, starting kind of with the airway, goal is to maintain O2 sac greater than 90%, especially in TBI patients, and then seeing if you have been able to achieve, normal saturation level with different maneuvers, or if you're going on the pathway of intubation. Obviously, in TBI patients, maintaining normal everything is what we always say. So normal blood pressure, normal body temperature, normal saturation. Try not to get their BP less than 100. Bolusing, giving pressors, sedation as needed. Do you see a lot of head injuries? Fair amount? Okay. Mostly probably from NBC, football.
We got a lot of biking trails.
Oh, yeah, okay. Okay, and this is the obvious target kind of crux of the study is saying that keeping the end tidal between 35 and 45, especially around that 40 range. You know the studies probably from American Heart Association for CPR, go through that with ACLS training, and know that is a great sign for indicating ROS, but they extended this study to evaluate patients that may need intubation or are already intubated and have a traumatic brain injury, that when end-tidal CO2 is used to monitor them, that they're being ventilated effectively overall. So much. Also decreases the case of the ventilator and multiple different benefits from it. So I'm very glad to hear that you have. When did you get that? When did you start using it? Long. That's great. Okay. Yeah, not everybody is saying the same. Okay, any questions on this? I think it's pretty self-explanatory. And I can also send these slides out too if we want them.
If there's any questions online, they can just unmute themselves and ask as well.
Okay. Yeah. Yeah, so this was one of the first studies that started to look at end-tidal back in 2004. So started to get some data for the pre-hospital setting and TBI patients intubating. There is a lot of debate about whether pre-hospital EMS should be intubating patients at all, and I know that there's a strong debate in the trauma surgery world where if the transfer is going to be a long time and it's going to be by air and this is less than 8, you're unencumbered. Obviously, they need to have an airway, but if it's going to be a situation where you're 5 minutes away, they have some debris in their mouth, they're not really protecting their airway, but you can back them. There is a discussion that, and especially if you don't have end-tidal CO2 capabilities, it's probably better for the patient to just get them to the center, let the trauma surgeons intubate where they have all the resources available rather than wasting the time to do RSI meds and potentially risk a difficult intubation. Okay, so what are the absolute indications for someone who needs to be intubated in the pre-hospital setting? Obviously, they're not protecting their airway. GCF less than 8 is the standard teaching, But I would say that between 9 and 12, it's use your best judgment. If they have other confounding factors or contributing factors where they're hypotensive, they stop responding to you, there's obviously you hook them up to end tidal and they're not ventilating, that would be an indication. So I would say that you are probably aware of all these indications, and anybody that presents to you that needs it, obviously. Where it gets kind of hairy is if they do have, let's say, person's talking to you and they have a stab wound to the chest or they're losing a lot of blood. You anticipate that they're probably going to need an intervention, but if you can still bag them, if they're still responding to you, you can bolus them and stabilize them and get them to trauma center and let us intubate and get them to the OR. Oh, and then agitation. I think overall in my experience, I don't know about you, but I did training in St. Louis, and Des Moines, there was a lot of drug use and very, very combative patients. So be very common that we would have the lifelike crew bring us patients who are really uninjured. They were so combative at the scene and NBC and put them down essentially for us to get them because they have to fly them 2 hours away and there's no way they're going to be able to stand a helicopter ride with the patient going hog wild in the back. So that would be another indication. Do you see a lot of combative patients in this area? Not.
We have a pretty good variety in this area. Freeway coming through the middle of it.
Yes. Yeah. PCS scores and scoring, I think it's sort of burned into my brain and sort of second nature, but may not be to everybody. So I put this up here as a reminder. Do you all think about this when you're evaluating patients, like kind of going through the scoring system? Okay. Very familiar then. And that's something that we ask for in the report. And I know that things can change, obviously, right? But I like to know PCS on when you first evaluate the patient and then during transport for change. So that's something that I specifically ask when for handoff. I like to know those details. Okay, so that's kind of airway, and then breathing as far as are the lungs functioning. I think the biggest reasons that you would have to intervene are in a patient who's, you know, hypotensive, right? I guess I should ask you these signs, but how would you evaluate a patient who has attention pneumothorax? Who you evaluate? And like the dullness. Very hard.
That stuff.
Yeah. Okay. Yeah. And so how are you taught to decompress for? I think you said third intercostal for anterior midclavicular and fourth if you're in the axillary.
I said
Good. Okay. Cool. Yeah. No. That's great. ATLS, the 13th edition, has now transferred all recommended decompression to the axillary, so it's important that you can go a little bit higher, but that's just to avoid thinking. And they also surmise that there's going to have to be a chest tube, obviously, that we have to put anyway. So going in that axillary line that kind of decreases their risk of having infection from one or multiple stabbings. And they results from the last 2 years after they put out that recommendation, have actually shown improved sort of rates of decompression and success with the accidental. I think that it's fine to do both as long as you know kind of where you're going and you have a deep enough needle. Probably for some larger patients that you're seeing. Growth phase.
APLS is recommending all of them be down.
Yes. Yeah. And that was the 13th edition, which came out through. I don't think it's crossed over to everything. So yeah, we know these are kind of the major injuries that we can see with patients with traumatic injuries to the chest. And I would say, obviously, anybody who has an airway obstruction, that's why A is number one. It's the scariest. And let's say that you're in a situation where you've tried to intubate, and whether you have a light scope or whatever you're using for a blade, you probably don't have any video scope, something like that. You just you do. You do. So just with the small. Okay, so you're not able to visualize the cord. There's a lot of blood. Maybe there's a tooth down there, and you get function that you can't get it out. Kind of bougie. But you're able to back. What is your next step after? Okay. And what do you use for tube size?
We have a chronic kit.
You do, okay. And it comes with the tube. Okay, so you don't have to gather those supplies. Okay, so there's probably a knife and Kelly's.
So we don't have a scalpel kit. We have two separate kits. We have one scalpel.
Okay.
Where it just goes with the tube just goes right. So once you get your lab.
Yeah. I feel like it's all in your technique. But it's probably not a big tube. Probably not like a size 17. Really? Okay. That's interesting. I'd love to see that kit. That sounds amazing. Okay.
Yeah, I didn't answer for me though, if I didn't participate.
Anyone?
Like a YouTube that I can get in there.
Oh,
That's
yeah.
probably
Yeah.
what I'm using.
Exactly, right? Yeah. Okay.
So,
Yeah, yeah. And then every crack has to be then transitioned to a transcript. As long as it's big enough to pass some air. Honestly, you could just put an angio cap in there.
And I don't even have the option.
scalpel, finger in a movie.
Awesome. Hello.
Hey, Joe, can I back you up on that list?
Yeah.
You were talking about education. Okay,
No, because they're probably still ventilating fine. But you would say, oh well, yeah, I've got them stabilized. They're still hypotensive, and title's probably going to actually be fine. Yeah. Does it have an alarm on it? Like if it drops, does it have an alarm? Yeah. Have you seen a lot of like these sucking chest wounds? Have you had to apply the since prison? Oh, I didn't know there was a prison in there. Okay.
Used to be right down the street.
And Draper? Okay. And now it's up.
So,
Got it. So the only sucking chest wounds that we see, they have already kind of been treated, but you have tegaderm, so you just use those. All right, so,
There's a rule with sucking chest wounds in the trach size is forgotten, but it doesn't have to be more than. Each might not.
so when they have,
Be a sucking chest wound, it's got to be bigger. Portion of the diameter of the trach or something.
in like, as far as actual injury too? Yeah, so you can actually, it's kind of been debugged, this myth. So as long as there's a connection to the tracheobronchial tree and the outside, it doesn't necessarily have to be a certain size, just based on recent studies in the ATLS protocol, but it used to be a third. That we were taught in the younger years, but you can see it with anybody, typically a stabbing or a gunshot, and very, very few iatrogenic just from barotrauma. Yeah, any connection there is going to give you that rip roaring air leak, essentially. And then obviously when we put in the chest tube, we don't put it either operatively, surgically correct, so over, do some kind of bypass of the trachea. Just let it seal on its own, depending on how big it is. With the CT imaging that we have right now, we can do 3D. They've been able to pick up on. They proved that wrong. All right, so then finishing out the ABCs with circulation. Anybody who's hypertensive, you're going to get great IV access and give them fluids. Do you have blood? You have TXA? You do? Okay.
What's the preference with fluid?
So that's a very good question. I prefer plasma light, but nobody has it. I've only seen it on the East Coast. It's the most physiologic of any of the liquids, but it's very, very expensive. It does not matter. I would say NS is great, especially if you're worried about TDF. That's just going to help maintain their osmolarity and osmolality and prevent cerebral edema. But honestly, anybody can handle LR. Even in a burn patient, worrying about potassium levels, it's very, very minimal. You're not going to overdo it with that. It's something that we really have to worry about burn patients. There is not one that is better than the others in osmolality, but that's not given it. Makes sense. That's a good question. Any fluid.
Put some plasma.
Warm. Probably can't give it warm, but do you have a rapid infuser at all? You just use that. That's your rapid infuser. Okay. And then are there lifelike groups that go, I don't know if they serve.
Their line up, we have.
Okay. Because they have blood, and I know that we're getting a helicopter based out of, I think, Westlake.
Yes.
Okay. So we've gone over the protocol for resuscitation with them.
We got the helipad built out there.
Yeah. And so that's the plan.
Turn on Redwood Road and search up the older section.
Thank you. I knew that that was happening soon.
Yeah.
But anyway, that just, when you start giving blood that reacts, then it's very important so that we know. But obviously, any fluid that you give is very important for us to know how much and when and all this, which you already given them for. TXA, I'm very glad that you have it. What are your guidelines to give it?
1 gram.
Okay.
As long as the injury is very thin.
Okay.
No. Okay.
And they have to be above 14.
32.
No, 14 years old.
Oh, 14, okay, okay, good. That's interesting. There are some trials that I think are very important. These crash trials, so looking specifically at KXA and trauma patients, but really in anybody who's a lot of blood, the GI bleeds, will be affected in the first 3 hours. Injury or activation of MTP, as shown in now more than 50 patients in all the studies that they've done. Also helps decrease the length of hospital stay. Over resuscitating patients and help with reversing their cardiomyopathy. So,
Does that matter, or is it specific if it's an upper or lower GI? Typically, it's hard for us to quantify how much blood loss from hospitals. You see it in the toilet.
yeah,
One drop of blood could go 500 to 2,000 milliliters.
Right.
So to justify doing TXA in that situation versus somebody who got a car.
yeah, no, so unless if there's a question, I would say, unless you're more than 3 hours away from the hospital, then you don't necessarily get it. If you're questioning whether you should.
If you're more than 3 hours away, you don't get it.
Well, if you're
You're 5 minutes.
exactly, so I would say that unless you're absolutely 100% certain that they're emerging in front of you, then it's not really necessary. You can make that determination. But as far as traumatic brain injury patients go, it actually does help with their survival and their recovery in any TBI. So it doesn't matter what it is. That's skull fractures, any frontal injuries. So backing up to the CRASH 2 trial, basically in people that are hemorrhaging. So they are in a car crash and have polytrauma and distended abdomen, broken femur. We will make sure that it is given within 3 hours of the injury. So I think this is mostly applicable to any lifelike group. They will usually call us and say, hey, do you want us to give it? Or they know, yes, we've already given blood. There is this 3 hour window. It's not technically an hour. It's great that you do give it within an hour. So I like but then we, in the next 8 hours, give the second dose. So this idea, yes.
To interrupt that.
Yeah.
Would you say 3 hours to a hospital from the time they determine it's transport, or 3 hours from the time of onset of that hemorrhage? Because
Yes.
in my mind, they could have been 2 hours before we finally got called. So in reality, they should get it versus no.
Yes. Yeah. So that's a good point too. And I realized that you are being called in areas where you might have been laying down or somewhere unresponsive and bleeding for who knows how long. So I think it's better to give it. The side effects, the poor side effects are not that bad with giving TXA to someone who may not need it or if it's past that 3 hour mark. You're not really going to harm the patient, for instance. So I would go ahead and give it if there's any question or if you're not sure how long they've been down. Better to go ahead and give it, and then if we feel like their second dose is necessary, then we'll not going to make them worse by giving it, and it's like 4 hours after they started bleeding. If it's been a day or, and they're still alive and they're bleeding like that, then that's a different story. So,
About the dosing, 2 grams.
yeah, that hasn't come through our guideline through the Brain Foundation guidelines or from ATLS and the AAFC through American College of Surgery. So I know that they're still kind of introducing that concept. I don't think that it's going to change anytime soon. Has has the recommendation for your administration changed?
No, where I used to apply so recently.
Yeah.
Typically, the company I would work with stuff that was not necessarily from our surgeon per se, but made sense with the emergency physician.
Okay.
So like C-collar, for example, we stopped putting C-collars on patients. Because it just
Yeah.
You know, and oftentimes you go to the ER and these guys encounter from time to time going through primaries. You're following a guideline protocol, you're gone.
Yeah.
But they haven't necessarily.
Yeah.
So I understand that direction, that's too many values.
Yeah, I don't think that nationally it will. So at Virginia Tech, there are a lot of different sort of study protocols going on right now, and that was one of them. So one of the trauma surgeons had sort of this test program going on, but I think that's like what you're saying, few and far between, not going to be the standard, unless there's going to be a big meta-analysis that it's significantly better at reducing mortality.
So, people online are just saying that if we can repeat the question.
Oh.
Hear better.
Yes.
So,
Okay, so the question was, do I think that there's going to be a change in the dosing and going to 2 grams of TXA, which some centers across the country have experimented with, but there's not a randomized control study or systematic review or change to the guidelines that is happening right now. So
we have an update on, as of March 18th on our protocols.
really, well, that's great. So remind me, what was that district? What was the?
Because we have local district 2B protocols that from the ballot, basically all the standing order.
Okay.
So you go to their website and then you can update.
Oh.
I think I looked at it like a week ago.
Okay.
Then it looks like it was adopted on March 18th.
That's very
It
interesting.
says 2 grams IDIO. So. And it's for patients with severe hemorrhage.
Oh, that's great. We'll see if anything, the Clinical Congress, we just had the East trauma guidelines and Western trauma, so we'll see if anything comes of it. To be determined. Yeah, but we'll also see if your guidelines start to include TBI patients too, because this data is very poignant and like with the CRASH 3 trial, it definitely decreases mortality.
What kind of patients would be excluded? In the past, it was TBI and pregnancy. I think my mind was doing too, but those 2 are actually included. Right? So what patient criteria might you exclude?
For TXA? Basically, it's just a time game right now. So if you feel like it's been really much longer than 3 hours, then they're not going to benefit. So you must have, like, is it like an app or is it just on the website?
On their website.
That's great that you have that. Bottom of the
Yeah,
page.
if you go down to the bottom, TX, the 2 are.
They haven't linked
with each other.
Okay.
If you look at hemorrhage control, it still shows. It says TXA guideline and then it's got a date.
Yeah, great. I think kind of already have gone over this, and this was just the idea of, I think, going over trauma patient evaluation and who needs to be transferred faster and types of injuries that are going to be more severe. And yeah, telling like when, if they have any of these injuries, when to transfer to a trauma center or just follow your own protocol if they don't have any of them. But pretty much going through this, all trauma patients are going to a trauma center, some faster than others. I love at the bottom, when in doubt, transport to a trauma. Yeah, I think this is actually something that I found from EMS specific literature. Okay, so did all this. Now the patient's in the trauma bay. We'll redo all the ABCs and then we do a ultrasound fast exam. Do you have ultrasound? And get chest x-ray, pelvis x-ray, do everything, and then do a full secondary survey. So we go from head to toe and kind of like match on every extremity and look everywhere. So, okay, so I want to just, I teach ATLS and I think it's great to just kind of go through seeing your thoughts and what you would be doing for a patient like this. So let's say that you get a call or you're alerted about a car crash and you get there, it's a 30-year-old and hit a light post head on. So let's say that there's significant deformity to the car in the windshield and the patient is actually already out of the vehicle and was found 15 feet away. And you see that airbags were deployed in the car. When you get to the patient, turn him over, and he's not really responsive, has kind of fast, sort of shallow respirations. His extremities are cool and clammy. Pulse is kind of thready and pretty high. Then looks like he has some damage to frontal skull with scalp laceration, lots of bleeding, some debris already in it. And then maybe some ecchymosis all around. On the left side, there's some crepitus, lots of blood, and then you feel like maybe there's a few broken ribs. The right lower extremity looks a lot bigger than the left, particularly the thigh, and it's externally rotated and kind of bent a little bit. Those are his vitals. Once you assess him, still 80% on just the 15 liters. That's how far you are from, I guess. So, what would your thinking be about this patient and what would you assess first? What would you do first?
Possibly as cardiac.
Okay, and then blood pressure.
So we've got.
Okay.
So that brings up a question too. You said trauma 1 center. Do you do trauma 2 center as well? What's the difference between trauma 1 and trauma 2 center? Education, research. So like your trauma 2 is down in Utah County, your trauma 2 is here at St. Mark's, or can take the same patients basically, except for very specialized injuries as part of that case. Like your burn patients are going to want to go to EU. Your microvascular stuff, the amputations likely go to IMC. Everything else they can handle at the trauma 2 trauma 1.
Yeah. Okay. So where could he be losing blood from? Okay. Yeah. Yep. So, and can bleed out from a scalp laceration. So basically blood on the floor. So chest, abdomen, long bones on the floor. You can bleed out from a lot of places. But with him in particular, might have, obviously expanding hematoma. vessel injury near femur fracture, so femoral, superficial femoral artery in the thigh, and I don't know what's going on with the chest, and it has this skull laceration. So what do you have for controlling hemorrhage, like stop the bleed type of? What is it? Quick clot? Okay, okay. So dumping a bunch of quick clot and then wrapping Ferlex or some kind of that wrap. All right, so we get the patient, and this is something that you were talking about. Probably don't read a lot of X-rays, right? So you can see that there aren't any lung lines over here. So you see these lung lines, and like whole ventilator lung over here. But what do you see over here on the left side? So lung is very collapsed right there, and then that's air, and then what else do you see? Yeah. So trachea is deviated, means that you can also probably see some DVD on the patient, right? Well, okay, so then there has not been an intervention on this one, but yeah. And that's right at the hiatus where your SFA kind of touched down. Site of injury to big vessel in the leg, and probably is injured. Okay, so this is the CT, the skull fracture there, subdural, probably some subarachnoid, and not as big, but you also see midline shift. It's not significant, it's only like 3. The ventricle here is depressed, lots of swelling on the side. Kind of a poor image, but there might be some anywhere too. So that's the telltale sign of axonal injury on a CT is when you can't differentiate between the white and the gray matter at all. Which that kind of already does. But this is a pelvis X-ray, and what do you think about that? I don't see anything wrong with it. It's actually a normal X-ray. He has some air in his sigmoid colon going down to his rectum, but other than that, nothing. And the pubic symphysis is together. This one's a little bit different. I'll go back. But looking at the symphysis there versus here, that's why. So, do you have a pelvic finder? Okay. Is it like IPOM or what?
It's a SAMS tool.
Okay, so do you have like collatus and Velcro with it?
Velcro and whole system that has a 2-1.
Got it. Okay. Where would you feel to put it properly on a patient? Okay. Meaning, like, where you feel their hips or where their actual hips are? Okay. What do you say? So you want to actually compress the greater trochanters. So you don't want to do the anterior superior iliac spines, which is typically where you like hold baby on your hip, right? Or you feel someone's hip. If you put it here, you're actually going to make this wider. Like you're compressing here. So what you want to feel for is kind of where their actual femurs go into their hip bones. The greater trochanters right here. Lower. So it's going to be over kind of their genitals essentially, push all that together. Yeah, that's Well, questions or anything to discuss? Okay. Welcome. I'm glad.
Any questions online? See,
Yeah, maybe back to the slide with that.
Which one?
Just listed randomized control trial.
For like Crush 3? Oh, maybe I passed it. There.
Okay, well, if there's no questions online, no questions here, thank you for being here. And all of you online, you missed out on steak and mac and cheese today, so sorry. Okay, well, I appreciate you guys being here and thank you. Have a great day. Yes, 40.
Okay.
Thank you.
Thank you.
You get to pick up some information from them as well.